Hi everybody, and welcome to our module on the gastrointestinal blood supply. This is a drawing of the abdominal aorta. The diaphragm is up here as I've marked on the screen. Down at the bottom is the branching of the aorta into the common iliacs and then the external and internal iliacs. And there are three major branches that come off the abdominal aorta that supply the gastrointestinal organs. The first one is the celiac trunk, the next one is the superior mesenteric artery, and the third one is the inferior mesenteric artery. There are a couple of smaller branches off of the abdominal aorta. Those include the renals right here and the testicular and ovarian branches, which are here. But what we're going to focus on in this module is the three major branches that supply the gastrointestinal structures, and those are the celiac trunk, the SMA, and finally the IMA. Let's start our discussion with the celiac trunk. On this slide, I've listed the key points you should remember about this branch of the abdominal aorta. The first thing you should know about the celiac trunk is that it supplies the embryologic foregut structures. Each of the major branches of the abdominal aorta, the celiac trunk, the SMA, and the IMA, supplies a different embryologic portion of the gut. The celiac trunk supplies the foregut, and as we will see, the SMA supplies the midgut, and the IMA supplies the hindgut. And the foregut structures that are supplied by the celiac trunk include the esophagus, the stomach, the liver, the gallbladder, and the spleen. We'll see a picture of that in a minute. This branch of the abdominal aorta also supplies parts of the duodenum and the pancreas. It has three major branches. The first one is the common hepatic, the second one is the splenic, and the third one is the left gastric. Here is a drawing of the celiac trunk and the three major branches. This is the abdominal aorta, and this is the celiac trunk. Going to the right side of the body, the first branch here is the common hepatic artery. Going to the left side, it gives off the splenic artery. And then coursing superiorly, it gives off the left gastric artery, and the first little branch off the left gastric is called the esophageal artery, shown going up here towards where the esophagus would sit above the stomach. All the blood supply to the stomach derives from the celiac trunk, and on this slide I've shown all the arteries that supply blood to the stomach. This is the lesser curvature of the stomach, and this is the greater curvature of the stomach. The lesser curvature receives blood from the left gastric and the right gastric. The left gastric artery, as we talked about in the last slide, comes directly off the celiac trunk. The right gastric, on the other hand, usually originates from the proper hepatic artery. The common hepatic artery branches to give off the proper hepatic heading up towards the liver, and the gastroduodenal artery heading downwards, and the proper hepatic usually gives off the right gastric artery. On the other side of the stomach, we have the greater curvature. That is supplied by the left and right gastroepiploic arteries. The left gastroepiploic is a branch off the splenic artery, as shown here. The right gastroepiploic comes off the gastroduodenal artery. And then finally, the top portion of the stomach here is called the fundus of the stomach, and the cardia of the stomach is where the esophagus enters. And the cardia and the fundus are supplied by short gastric arteries which come directly off of the splenic artery. The most important clinical correlation of the blood supply to the stomach and the celiac trunk has to do with perforated ulcers. Perforated ulcers are extremely rare in the modern era, but before we had acid-suppressing drugs, these were a routine occurrence in major hospitals. If you were a surgery resident in the 1950s or 1960s, you would operate many times per week on patients who had perforated ulcers because we didn't have good medical treatments for them. So during that period of time, a lot was learned about why ulcers bleed and how they cause bleeding. And one thing that people learned was that gastric ulcers in the stomach were common in the lesser curvature, and when they ruptured, they would cause bleeding from the left gastric artery. If we go back to our picture, this is the lesser curvature of the stomach, and when ulcers would develop here and perforate into an artery and cause bleeding into the stomach, that artery would usually be the left gastric. Another common location for ulcers that would perforate were in the posterior duodenum, and ulcers that perforated here and caused rupture of a blood vessel resulted in bleeding into the duodenum from the gastroduodenal artery. Once again, we'll go back to our picture. This is the gastroduodenal artery coming down to supply the pylorus and the proximal portion of the duodenum. Posterior gastric ulcers would occur here, and they would cause bleeding into this gastroduodenal artery. Another clinical tie-in with the blood supply to the stomach has to do with the short gastric arteries. These are 5 to 7 small vessels. They're branches of the splenic artery off the celiac trunk, and they supply the upper portion of the stomach, the fundus, and the cardiac portion of the stomach. I'll show you that in a minute. And they're vulnerable to ischemia if the splenic artery becomes occluded because unlike other parts of the stomach, this does not have a dual blood supply, and you can contrast this with the gastric and gastroepiploic arteries which have dual sources. These are the short gastric blood vessels here which supply this upper portion of the stomach, and they arise off of the splenic artery. So if you have a thrombus in the splenic artery, which is relatively rare, but if this does occur, then these small, short gastric arteries will lose their blood supply and you'll develop ischemia up here. Ischemia is much less likely to occur in any of these portions of the stomach supplied by the left and right gastric or the gastroepiploics because they have dual blood supply. If the splenic artery is occluded, that might stop blood from flowing to the left gastroepiploic, but you would still get blood this way via the right gastroepiploic. Also consider if blood stopped flowing for some reason through the left gastric here, you could still get blood to the lesser curvature via the right gastric artery. The one place in the stomach that does not have a dual blood supply is this area up here supplied by the short gastrics. There is another clinical tie-in that has to do with the blood supply to the stomach and the celiac trunk, and that has to do with the structure called the hepatoduodenal ligament. This is a structure that connects the liver to the duodenum. That's why it's called the hepatoduodenal ligament. And it's found on the free border of the lesser omentum. I'll show you a picture of this in a minute. And it contains three structures. The first is the proper hepatic artery, which is a branch of the common hepatic artery. The second is the portal vein, and the third is the common bile duct. Recall that the common bile duct branches into the cystic duct, so sometimes you also find a portion of the cystic duct within the hepatoduodenal ligament. And also recall from some of our other videos that these three components are what make up the portal triads in the liver. So it's basically those connections to the portal triads in the liver that pass through the hepatoduodenal ligament. One place where the hepatoduodenal ligament is important clinically has to do with something that is done in the operating room by surgeons called Pringle's maneuver. Surgeons will sometimes clamp the hepatoduodenal ligament in order to determine where a patient is bleeding from if they have internal bleeding. What this will do is control the bleeding if the source of blood in the abdomen is from either the portal vein or the proper hepatic artery, one of the two vessels that lies within the hepatoduodenal ligament. If the bleeding continues despite Pringle's maneuver, in other words, if it continues despite clamping this ligament, then that means that the bleeding must be coming from either the IVC or the hepatic veins, and that's because both of these structures do not run through the hepatoduodenal ligament. This is the proper hepatic artery that is contained within the hepatoduodenal ligament. You can see it's a branch off the common hepatic. This is the common hepatic, and it gives off this proper hepatic artery here. It then splits into three vessels, the cystic artery, the right hepatic artery, and the left hepatic artery to supply blood to the gallbladder and the liver. And here's a drawing of the hepatoduodenal ligament. So this is the lesser curvature of the stomach, and this is the lesser omentum, which is between the stomach and the liver. The lesser omentum is connected to the stomach, but it has a free border here that is not connected to the stomach, and that's where you find the hepatoduodenal ligament. And within that ligament, as is shown in this picture, you can find the common bile duct, the portal vein, and the proper hepatic artery. The surgeon clamps this during Pringle's maneuver to obstruct blood flow through these vessels, and if that stops the bleeding, then one of these vessels was the cause of the bleeding. The next major branch of the abdominal aorta is the superior mesenteric artery, or SMA. This supplies all the embryologic midgut structures. As I showed you before, the celiac trunk supplies the foregut, and we'll see in a minute that the inferior mesenteric artery supplies the hindgut structures, but the SMA supplies the midgut structures. Those include the distal duodenum, the jejunum and ileum, the cecum, and the appendix. Also supplied by the SMA are the ascending colon and the first two-thirds of the transverse colon. This blood vessel courses across the head of the pancreas and across the duodenum, and this course is important because, as we'll see in a minute, there is a rare clinical syndrome where the SMA compresses the duodenum and causes a bowel obstruction. Here's a picture of the SMA and its major branches. It comes off the abdominal aorta and courses right over the top of the duodenum. On the right side of the body, it gives off the right colic artery and also the ileocolic and also the middle colic, and these supply blood to the ascending colon and the transverse colon. On the left side of the body, it gives off a series of ileal and jejunal arteries, which form something called arcades over here. I'll show you a picture of that in a minute, and supply blood to the small intestines. Arcades and the vasa recta are features of the blood supply to the small intestine. Arcades are anastomoses of ileal and jejunal arteries. As you can see in this picture on the screen, lots of these arteries link up together in anastomoses, and those are called the arcades. The vasa recta are arteries that extend out from the arcades and go out in this direction to supply blood to the intestines. An important clinical tie-in of the superior mesenteric artery is a rare phenomenon called the SMA syndrome. This is a very rare cause of bowel obstruction. As we saw 2 slides ago, the SMA courses over the distal third of the duodenum. The distal duodenum is stuck between the aorta and the SMA, but there is mesenteric fat that keeps the superior mesenteric artery away from the duodenum. If for some reason the SMA presses downward, it can compress the duodenum and cause obstruction. And this sometimes occurs when patients have massive weight loss. That fat pad shrinks, and the SMA compresses the duodenum. Going back to this slide, you can see how the SMA courses over the duodenum, and if it were to press downward for some reason, it could pinch the duodenum, and this sometimes occurs when people lose lots of weight, and it's a rare cause of a bowel obstruction. The last major branch of the abdominal aorta is the inferior mesenteric artery, or IMA. This supplies the embryologic hindgut structures. Those include the last third of the transverse colon, the descending colon, and the sigmoid colon. Here's a drawing of the inferior mesenteric artery. The first major branch is the left colic, which supplies blood to the distal portion of the transverse colon and the descending colon. There are then a series of sigmoid arteries which supply blood to the sigmoid colon. Now that we've talked about the three major vessels that branch off the abdominal aorta, let's talk about dual blood supply areas. There are portions of the abdomen that receive blood from two of the major vessels that branch off the abdominal aorta. These parts of the abdomen are said to have collateral circulation, meaning circulation coming from more than two of the large vessels. And by having a dual blood supply, this protects against ischemia. The first collaterals we'll talk about are those between the celiac trunk and the SMA. If you look at this drawing on the left side of the screen at the bottom, this shows the celiac trunk, and this small branch right here is called the superior pancreatico-duodenal artery. Over on the right, we see branches coming off the SMA, and this little branch right here is the inferior pancreatico-duodenal artery. Both of these vessels, the superior and inferior pancreatico-duodenal arteries, are going to give off branches that link up together. This is called anastomosing, and this is going to allow blood supply to the duodenum and the pancreas to come from either the celiac trunk or the SMA. And that's the idea behind a dual blood supply area. This protects against ischemia. The second important collateral is between the SMA and the IMA. This occurs in the marginal artery of Drummond. If you look at this drawing of the transverse and descending colon, there is this blood vessel that courses along the transverse colon and down along the descending colon. That vessel is the marginal artery of Drummond, and it receives blood from the SMA and the IMA and provides protection against ischemia to this portion of the colon from vessel occlusion. As we'll talk about later, this portion of the colon can get ischemic when blood pressure is very, very low, for example, in shock, but it's very rare for this portion of the colon to get ischemic from a vessel occlusion because, for example, if the SMA was occluded, blood could still reach the marginal artery of Drummond via the IMA. The third important collateral is between the IMA and the iliac artery. This occurs in the rectum. The superior rectal artery, which is a branch of the inferior mesenteric artery, merges with the middle rectal artery, which is a branch of the iliac artery. I've shown that in this drawing on the screen. This is the common iliac, and it gives off the internal iliac, which branches to give off the middle rectal and supply blood to the rectum. Also supplying blood to the rectum is the superior rectal artery, which comes from the inferior mesenteric artery. Thus, the rectum has a dual blood supply, and rectal ischemia from occlusion of a vessel is rare. Now that we've finished talking about the blood supply to the colon, I want to finish this module by talking about intestinal ischemia, and the first thing I want to do is define a couple of terms. The first term is mesenteric ischemia, which means ischemia of the intestines. And the most severe form of mesenteric ischemia is that which involves the small bowels. This is a life-threatening condition and carries a very high mortality rate. Ischemic colitis means ischemia of the colon, and the reason it has its own term is because ischemia of the colon tends to be less severe than ischemia of the small intestine. It sometimes spontaneously resolves. And for this reason, when people are talking about ischemia of the colon, they often call it ischemic colitis. And when people are talking about ischemia of the small bowel, they often call it mesenteric ischemia. So let's talk about the causes of mesenteric ischemia. Why would this happen to someone? Well, the most common cause is an embolism, and these emboli often come from the heart. There can be a thrombus in the left ventricle. There can also sometimes be a thrombus in the left atrial appendage in patients with atrial fibrillation. And a classic board question is someone with belly pain from ischemic colitis, and they ask you where you should check next. And you look for something that has to do with the abdomen, but in fact you should order a test to check the heart for atrial fibrillation. And these clots from the heart tend to affect the jejunum the most. That's because they tend to go to the SMA and lodge in branches of the SMA that supply the jejunum. Second reason that people can potentially get mesenteric ischemia is from arterial thrombosis. This usually occurs at the site of atherosclerosis, and this is like a heart attack occurring in the intestines. There's a plaque and it ruptures and forms a clot. Patients can also sometimes develop venous thrombosis. A clot can form in the venous system, and this can create resistance to flow out of the mesentery, and this can lead to ischemia. This is one of the least common causes, but it does occur. And when this happens, it's usually for the usual reasons that people get venous thrombosis, like hypercoagulable states or malignancy. And then finally, many patients develop what's called non-occlusive ischemia. This is when they have underperfusion of their intestines from some form of shock. This usually does not affect the small intestine. It usually affects watershed areas of the colon. I'll show you these in a few slides. These are the areas of the colon with the weakest blood supply, and this often results in ischemic colitis, not mesenteric ischemia. The symptoms of mesenteric ischemia are usually sudden onset abdominal pain and cramping. The physical exam in mesenteric ischemia is very important. The classic finding is pain out of proportion to exam. Usually these patients have only mild tenderness. Some even have no belly pain. They have no rebound tenderness, no peritoneal signs, and you have to have a high degree of suspicion clinically to diagnose mesenteric ischemia. People are often falsely reassured by a benign physical exam of the abdomen when the patient is saying that they have severe abdominal pain. Another finding that can tip you off to mesenteric ischemia is occult blood in the stool. The ischemia leads to bleeding, and if you take a stool sample and test it for blood, you will find that there is blood present. You may see elevated white blood cell counts, and you may see a lactic acidosis present from ischemia to the bowel. Now let's talk about those watershed areas I mentioned before. These are parts of the colon that are located between the major vessels, and they're at risk for ischemia when there is systemic shock or hyperperfusion. Ischemia to these portions of the colon often occurs in ICU patients who are hypotensive and on pressors. The first watershed area is the splenic flexure. This is supplied by small blood vessels of the marginal artery of Drummond, and the marginal artery of Drummond itself is very small, and this makes the splenic flexure vulnerable to underperfusion. If we go back to this slide, this is the marginal artery of Drummond, and the splenic flexure here is the furthest away from the SMA or the IMA, so being that far away from both of the blood vessels that supply the marginal artery of Drummond sets it up for ischemia if there is systemic hypoperfusion. The second watershed area is the rectosigmoid junction. This portion of the colon is supplied by narrow branches of the IMA, and this sets it up for ischemia. If we go back here to our picture of the inferior mesenteric artery, the rectosigmoid junction in here is supplied by narrow branches off the IMA, and it tends to be vulnerable to ischemia just like the splenic flexure. Now everything I've told you up to now is about acute mesenteric ischemia, but there is something called chronic mesenteric ischemia, which is sometimes called intestinal angina, because it's similar to angina in the heart. This usually occurs in older patients who have risk factors for vascular disease. They may be a smoker, they may have diabetes, they may even have known peripheral arterial disease such as obstruction to blood flow to their legs. These patients develop recurrent abdominal pain after eating. They can get so afraid of the abdominal pain that they develop a fear of eating and weight loss. And this occurs because when you eat, you demand more blood supply to your intestines, and these patients cannot meet that increased demand, and thus they develop ischemia. This is the same pathophysiology of angina in the heart, hence the name intestinal angina. Sometimes these patients develop a sudden worsening of abdominal pain on top of a history of recurrent pain, and when you see this type of history, that suggests an acute thrombosis on top of a vascular plaque. That concludes our module on GI blood supply.